I have no relevant financial disclosures to make. Anemia is defined as a hemoglobin or hematocrit that is more than 2 standard deviations below the mean for age and gender. It is useful to note that the norm changes over time. At birth, there is a relative polycythemia, following which there is a dramatic drop in erythropoiesis due to the higher tissue oxygen content, with a subsequent decrease in erythropoietin. This leads to a gradual decline over the first few months of life to what we call the physiologic nadir at around 6 to 9 weeks of age. And the nadir is later and more pronounced in premature infants. Values then incline to reach adult values in late adolescence, with boys having a significant increase in their hematocrit over the course of puberty. This is a graph that shows the normal values for hematocrit and hemoglobin in infants, with age in months on the x-axis and the hemoglobin in yellow and the hematocrit in green. And it just emphasizes this steep drop-off that happens right after birth to a low point at around 2 months of age, and then a gradual increase again, such that by a year of age, things are relatively stable, although there is an increase again during puberty. I like to think of anemia in one of 2 broad categories. There's anemia due to inadequate production of red blood cells, and there's anemia due to excessive loss. And this can be either from destruction of red blood cells, from hemolysis, or from bleeding. Sometimes both factors are at play, and anemia can also be thought of as acute or chronic. It may be a congenital condition or acquired, and there's a very wide spectrum of severity that we see in pediatrics. There are some very useful laboratory parameters in thinking about the approach to a child with anemia. And perhaps the most useful is the reticulocyte count after one has already examined the complete blood count. The reticulocyte count is the most useful indicator of the adequacy of red blood cell production, but it needs to be interpreted in the context of the severity of the anemia, such that a normal reticulocyte count of 1 to 2% is not normal or appropriate in the face of severe anemia. The other very useful laboratory parameter that we often use to categorize and classify anemia is the mean corpuscular volume, or the MCV. This is a measure of red blood cell size, and of the red blood cell indices that we obtain with the CBC, it's the most useful of the different indexes. We generally classify anemia as microcytic, with the most common microcytic anemia being iron deficiency, but also in this category are hemoglobinopathies, lead poisoning, and anemia of chronic disease. There is a normocytic anemia, and there is macrocytic anemia, where the red blood cells are large. These in general are uncommon in children, and most often are related to the use of medications, including anticonvulsants, zidovudine, immunosuppressants. It's also seen in vitamin B12 and folate deficiency, in liver disease, in the bone marrow failure syndromes, or if there is a brisk reticulocytosis, because reticulocytes are large, so if there are a lot of reticulocytes present, that can be a reason for an elevated MCV. It can also be part of congenital heart disease and seen in children with Down syndrome. The other red blood cell indices, the MCH, the MCHC, and the RDW, also provide information about red blood cell morphology that can be helpful in determining the cause of anemia. When taking a history in an anemic patient, there are several features that are important to focus on in trying to determine the etiology of anemia. Age of onset is very useful. Most of the congenital anemias present early in life, in infancy or in the first few years of life, versus an acquired condition when there's a documented previously normal hematocrit. That makes a congenital condition less likely. Nutrition is very important, what the child's diet is, whether there is a history to suggest malabsorption, and whether the patient has previously had bowel surgery with resection. History of underlying chronic disease. Very often anemia is a secondary condition to an underlying systemic illness. History of drug or toxin exposure or recent travel. History of infections that could lead to aplasia, to a hemolytic anemia, or parasitic infections that can lead to gastrointestinal blood loss. If there's a history of hemolytic episodes, including jaundice, scleral icterus, or a change in the color of the urine, this can point to an underlying hemolytic disorder. And asking about blood loss, with the most common etiology being bleeding from the GI tract that may be microscopic or may be overtly bloody. Asking adolescent girls about their menstrual history and for a history of heavy menses, that can be helpful in thinking about anemia in a teenage girl, or a history of frequent epistaxis. And finally, thinking about the race and ethnic background of the patient and their family history, because many of the inherited red cell disorders are prevalent in certain populations from different parts of the world, and I will come back to this. But a family history of anemia, jaundice, gallstones, splenectomy, all of those things suggest a potential familial hemolytic disorder. Thinking about whether the patient is actually symptomatic for their anemia. So symptoms really depend on the severity of anemia and the acuity of the anemia. How quickly did the anemia develop? Patients tolerate severe anemia quite well if it has unfolded over a long period of time. We see this in our sickle cell patients who can live at a very low baseline hematocrit in the 19 or 20% range, but be relatively asymptomatic. And that's because they've accommodated to that and acclimated, whereas a rapid onset of anemia of that severity will lead to the patient being much more symptomatic. Features to focus on the physical examination, vital signs, of course, the presence of congenital anomalies, including short stature, the mental status of the patient, particularly in the case of a child with severe anemia, where we're trying to make decisions about whether transfusion is indicated, the cardiopulmonary status, including looking for signs of congestive heart failure. Pallor is a tough one. Of course, pallor is the classic symptom of anemia, classic finding, but it can be very hard to determine whether pallor is present depending on the patient's skin color, and it can just be difficult to interpret. Looking at the conjunctiva, the mucosa, the nail beds, and the palms of the hands is a little more useful than general skin color. Looking for the presence of jaundice, scleral icterus, organomegaly, or frontal bossing is also important. The laboratory evaluation should be guided by the history and by the clinical presentation. A great deal can be learned from just looking closely at the complete blood count, the red blood cell indices, the differential, and again the reticulocyte count. And I think we all learned in medical school there's great value to closely examining the peripheral blood smear, not just to look for red blood cell morphologic abnormalities, but also abnormalities of the other cell lines, the platelets and the white blood cells. So I want to shift gears and start to discuss the anemias of underproduction. Again, thinking of anemia as either too little production or too much loss. Anemias of underproduction can be from nutritional etiologies, the most common, of course, being iron deficiency, which causes a microcytic anemia. Children can get vitamin B12 and folate deficiency, which lead to a megaloblastic macrocytic anemia. And rare but worth mentioning is vitamin E deficiency, which results in an oxidative damage to the red blood cells. And this is primarily seen in pediatrics in the setting of premature or very low birth weight infants, or in the setting of fat malabsorption. Iron deficiency is the most common nutritional deficiency in children, as well as the most common cause of anemia. And there are many important risk factors to think about when evaluating a child for possible iron deficiency. Poverty is an important risk factor. Maternal iron deficiency that can contribute to iron deficiency in the infant. Giving cow's milk or non-formula milk or a low iron formula in the first year of life contributes to iron deficiency, as does excessive cow's milk intake in toddlers, generally defined as more than 24 ounces of milk ingested per day. Obesity, prematurity, because babies are born with lower iron stores when they're born prematurely, being of low birth weight, underweight, or malnourished. Infections, in particular with hookworms, with Giardia or H. pylori infection, all of which can lead to GI blood loss and subsequent iron deficiency because of chronic bleeding. The ages that are at highest risk for iron deficiency are the 1 to 3 year olds, and then again adolescents, and in particular adolescent girls because of menstrual blood losses. These are the periods of rapid growth when iron requirements are at their greatest. A vegetarian diet, and in particular a vegan diet, place patients at higher risk. Plant iron is less bioavailable than animal iron. Blood loss of any kind in the newborn period, anemia can be related to blood loss that occurred prenatally from fetal maternal hemorrhage, perinatally around the time of birth, or of course any blood loss later in life. And finally, endurance athletes are at risk for iron deficiency. Having said this, iron deficiency is quite unusual in the first 6 months of life in healthy full-term babies, and this is because babies are generally born with good iron stores from the mother. So this is usually not a major consideration when a newborn has anemia. Interestingly, a focused dietary history is actually the most effective screening tool for iron deficiency. Iron is absorbed in the duodenum, so its absorption can be impaired in several different GI conditions, including Crohn's disease, active celiac disease, cow's milk-induced colitis, or if a patient has had surgical resection of their small intestine. Iron deficiency is so important to think about, to screen for, and to treat, not just for the anemia, but for the neurodevelopment of the child. Iron deficiency has been associated with impaired psychomotor and or mental development in infants. Iron deficiency affects auditory and visual pathways and can impact social, emotional behavior in infants. It's also been associated with cognitive impairment in school-age children and in adolescents, and it may contribute to the development of attention deficit hyperactivity disorder. And what's most interesting and important to note here is that treatment can actually correct or prevent these impairments. So we shouldn't feel like the damage is done. We should treat and identify this aggressively. The American Academy of Pediatrics, because of this impact on neurodevelopment, recommends universal screening for all children for anemia around a year of age, and this is often done in conjunction with the 9-month or the 12-month well-child visit. Repeat screening later, either in the second year of life or during the toddler years, is recommended for high-risk patients, such as premature babies, those who have dietary risk factors for iron disease, for iron deficiency, or those with underlying chronic disease. The minimum screen is generally considered to be a hemoglobin with a cutoff of less than 11 defined as anemia. But for most patients, a complete blood count turns out to be the simplest and most cost-effective screening tool that provides the most information. For high-risk patients for iron deficiency, if you're going to do one more test, the ferritin is very useful to include, because this is a value that tells you the status of the patient's iron stores, which is really kind of the endpoint when we're thinking about treating iron deficiency. We want to replenish the stores. The one caveat there is that ferritin is an acute phase reactant, so there can be false negatives if the patient has an underlying inflammatory condition. But in general, if the ferritin is low, the patient has iron deficiency. There are 3 stages in the progression of iron deficiency to full-blown anemia. The first stage is depletion of storage iron, which is measured by the ferritin level. The second stage, there is loss of the transport iron, which is measured by the serum iron level, in which the patient has iron-deficient erythropoiesis but does not yet have anemia. And an elevated RDW can be the earliest laboratory finding in this phase of anemia. And then there is the third stage when there's actually the onset of the microcytic hypochromic anemia. So microcytosis is a relatively late finding in this process. Anemia will correct quickly, generally, with adequate treatment. But the goal of treatment is not just to correct the anemia. It actually should be to replenish the iron stores. And in particular, I like to use a normal ferritin as the endpoint for treatment. Treatment may include dietary modification, such as withholding or limiting cow's milk intake. Usually oral iron supplementation is adequate, but in good doses of 4 to 6 milligrams per kilogram per day of elemental iron until the anemia is corrected, and then to continue iron for another 8 weeks or so, with the goal really being to replenish the iron stores and normalize the ferritin value. Iron can be given 1 or 2 times daily. Probably once is easiest for a family to comply with. So if I'm concerned that a family's not going to be able to do it, I try to make it as simple as possible with once daily dosing. Iron is better absorbed if it's given on an empty stomach and with vitamin C co-administered. Iron tastes bad. There's really no way to disguise this, and that often leads to poor compliance. I think it's very important to prepare families for this, explain the importance of treating the iron deficiency, including an explanation of the neurodevelopmental consequences of iron deficiency, so that they know that this may be challenging and the child is likely not going to like to take the iron, but it's so important. If the patient is complying and the diagnosis is correct, we can see a reticulocytosis within a couple of days and an increase in hemoglobin of 0.3 grams per deciliter per day. If there's no response at all in 2 to 4 weeks, we need to consider noncompliance, too low a dose of iron, which is a very common issue that I see, malabsorption for some reason, or ongoing blood loss, or that this is not the correct diagnosis as the cause of the patient's anemia. We do sometimes use parenteral or intravenous iron. The newer low molecular weight formulations are associated with a very low risk of serious allergic reactions. We tend to reserve this for patients who are really critically low with severe anemia, or for some reason they are unable to absorb or comply with oral iron. This is just a chart that shows the laboratory values when we're thinking about, is this iron deficiency or is this thalassemia trait? And the 2 major features here that help distinguish are the RDW, which is increased in iron deficiency, and again, that's an early finding of iron deficiency. This will be normal in thalassemia trait. And then the other very useful value is the ferritin, which of course will be decreased in iron deficiency and normal in thalassemia trait. Of course, in both, there's a microcytic anemia, so both the hemoglobin and the MCV will be decreased. Microcytosis, with or without anemia, with normal iron stores, in particular a normal ferritin, is almost always going to be thalassemia trait. Other considerations for a mild microcytic anemia include infection and anemia of chronic disease. But this is usually the major differential diagnosis for microcytic anemia in children, iron deficiency or thalassemia trait. We'll move on and we'll talk about the megaloblastic anemias. the vitamin B12 and folate deficiencies. The characteristics of these are that macroovalocytes are seen in the peripheral blood smear. There are megaloblastic changes if a patient has a bone marrow. There may be hypersegmented neutrophils with or without neutropenia, and when this is severe, there can also be thrombocytopenia. More than 95% of the megaloblastic anemias are caused by deficiencies of folate or vitamin B12, but in general, these conditions are rare in children. When they do occur, it is usually in the setting of some underlying GI abnormality, for example, in a patient who has had surgery and thus has impaired absorption of these nutrients. Folate deficiency is less common than it once was because our food supply is now heavily supplemented with folate, and this has been done in order to prevent neural tube defects in babies, supplementing the diet of pregnant women. Causes of folate deficiency include inadequate intake, such as when milk is boiled or goat's milk is being given to a child, malabsorption, as I mentioned, from small intestinal defects, increased requirements, such as in premature babies when there is active hemolysis and during pregnancy. Again, I would note this is not very common anymore. We no longer routinely supplement all of our patients with hemolytic disorders with folate because it is heavily supplemented in our food supply. And then the administration of folate antagonists such as methotrexate can lead to folate deficiency. The clinical features are a macrocytic normochromic anemia with or without neutropenia and with or without thrombocytopenia. The patient may have glossitis, depression, and altered cellular immunity. The causes of vitamin B12 deficiency include adequate intake, and the patients most at risk for this are the strict vegan vegetarians. Conditions that lead to malabsorption, such as autoimmune disease, inflammation, or surgical bowel disease, can lead to vitamin B12 deficiency. Or there can be defective transport, such as in the case of a transcobalamin deficiency. The clinical features are lethargy, anorexia, glossitis, and neuropathy, paresthesias. This presents with a macrocytic anemia, and the patient may have an increased plasma homocysteine level, which is actually seen in both vitamin B12 and folate deficiency, and an increased plasma and urine methylmalonic acid, which is only seen in the setting of vitamin B12 deficiency. I'm going to move to talk about the non-nutritional anemias of underproduction. There's a condition of a pure red blood cell aplasia, which is congenital and seen in the pediatric population. This is Diamond-Blackfan anemia. It is caused by an erythroid stem cell defect from a genetic mutation of ribosome synthesis, and it's usually inherited in an autosomal dominant manner. It tends to have its onset early in infancy, and 25% of these children will actually have anemia at birth. 80% have anemia by 6 months of age, and 90% by 1 year. Up to half of these children will have identifiable congenital anomalies, such as short stature, changes in the eyes, hypertelorism, neck, or thumb abnormalities. Patients with Diamond-Blackfan anemia are at increased risk of malignancy throughout their lifetime. The lab findings are a macrocytic normochromic anemia, and notably with a low reticulocyte count, or reticulocytopenia, and that's because this is a production problem. We will see an elevated fetal hemoglobin and often an elevated red blood cell adenosine deaminase. But if a bone marrow is performed, the marrow in general will be normocellular, but with absent erythroid precursors. These patients are often responsive to corticosteroids. We try to avoid using steroids in the first year of life because of their adverse effects on development. Sometimes these patients require transfusions. They can really be very critically anemic. But up to 25% of patients with this condition will have long-term spontaneous remission. Bone marrow transplant, when necessary, can be curative. There's another pure red blood cell aplasia seen in childhood. that is an acquired condition, and this is referred to as transient erythroblastopenia of childhood, or TEC. This is also a normocytic, normochromic anemia with a low reticulocyte count. And similarly to Diamond-Blackfan anemia, the marrow will look normocellular, but with absent red blood cell precursors. The mean hemoglobin at the time of diagnosis of TEC is 5.8. Half of patients will also have some mild neutropenia. To help distinguish this from Diamond-Blackfan anemia, it's important to note that this tends to occur a little bit later. The mean age at diagnosis is 2 years. The onset in general is between the age of 6 months and 6 years, but 90% of patients are older than 1 year at diagnosis, and this is the opposite of Diamond-Blackfan anemia, where 90% are less than a year of age. These patients will spontaneously recover in 1 to 2 months, and this is usually associated with an antecedent viral illness. This can be identified in at least half of the cases and is thought to be related to autoantibody against an erythroid progenitor. And I think of this condition as analogous to ITP, but affecting the red blood cell line rather than the platelet line. Often these patients can just be observed. If they have cardiovascular compromise in the setting of severe anemia, often defined as a hemoglobin lower than 5, they may require transfusion until they recover on their own. There are lots of other causes of red cell aplasia anemia that are acquired. These include infection, with the most famous virus being parvovirus, which can be particularly problematic when occurs in utero. Immunocompromised patients can have a more prolonged chronic course from parvovirus, such as patients with HIV, or patients who have an underlying hemolytic disorder and are dependent on a brisk reticulocytosis to maintain their hematocrit. If they then acquire parvovirus that shuts down temporarily their red cell production, they can very precipitously drop their hematocrit, and this is the so-called aplastic crisis that we talk about in patients with sickle cell disease or other hemolytic disorders. The hepatitis viruses, Epstein-Barr virus, and HIV are also associated with red cell aplasia. Renal failure is an important cause of underproduction anemia because of low erythropoietin levels. Hypothyroidism, which usually results in a normochromic normocytic anemia. Underlying systemic autoimmune disease, in particular lupus, or malignancy often from direct marrow infiltration, which we see, for example, in children with acute leukemia. There is one other entity that warrants mention. It's a rare condition known as congenital dyserythropoietic anemia. This is a chronic, mild to moderate macrocytic anemia characterized by ineffective erythropoiesis and a relative reticulocytopenia. This is quite rare. There are several different types, and the diagnosis is made on the basis of characteristic abnormal bone marrow morphology. Anemia of chronic disease deserves some mention here. This is a little bit of a wastebasket diagnosis. It is usually a mild condition with either microcytic or normocytic red blood cells and reticulocytopenia. And this is really a multifactorial condition and can include features such as shortened red blood cell survival, altered iron physiology, where there are adequate iron stores, but the iron is not able to be utilized because it's sequestered in the reticuloendothelial system. So these patients may have a low serum iron but a high ferritin level. There's often an inadequate bone marrow response to the degree of anemia and low erythropoietin levels. And the conditions most commonly associated in children with anemia of chronic disease are inflammatory bowel disease, underlying renal disease, and underlying autoimmune disease, again, lupus in particular. I'd like to talk next about aplastic anemia. This is a little bit of a confusing term because it has anemia in the term, but this is not just of the red blood cells. Aplastic anemia is defined as pancytopenia, so affecting the other cell lineage as well, in the setting of a hypocellular bone marrow. Aplastic anemia may be either inherited or acquired. The clinical symptoms come about from the cytopenias, so from anemia, from thrombocytopenia, from a low white blood cell count. In the acquired form, which is the more common form in children, it's often idiopathic, where we really cannot identify a cause, and we presume this to be driven by an autoimmune process, such that the treatment is often with immunotherapy, including antithymocyte globulin, corticosteroids, and cyclosporin A, and or bone marrow transplant can be curative for this condition. There are several forms of inherited aplastic anemia to consider in the pediatric age range. These are all relatively rare, but there are 4 major causes in children. And I would just mention that when they present early on, they may not have all cell lineages affected. They may just have a single or maybe 2 cell lines down. The most common of these conditions is Fanconi anemia. There's also dyskeratosis congenita, which is a telomere problem. There's Shwachman-Diamond syndrome, and there's congenital amegakaryocytic thrombocytopenia. Fanconi anemia is pancytopenia with the macrocytosis. It's generally inherited in an autosomal recessive or in an X-linked manner, and it is a DNA repair defect with excess chromosomal breaks. Most patients are diagnosed between the age of 3 and 14 years, with the mean age at diagnosis being 9 years. More than half of these patients have other congenital anomalies, such as short stature, skin pigment changes, eyes, renal, genitourinary, cardiac, or thumb anomalies. These patients also, like Diamond-Blackfan anemia patients, have a significant predisposition to malignancy. This is a premalignant condition, and in particular, they can develop myelodysplastic syndrome and acute myelogenous leukemia. Bone marrow exam shows a hypocellular marrow with increased fetal hemoglobin because there is stress erythropoiesis, and this can be treated with androgens, but most definitively with bone marrow transplant. We'll shift gears now to talk about the anemias of excessive loss. We just covered the anemias of underproduction. Again, there are 2 major forms of this. There's blood loss, and then there is accelerated destruction of red blood cells, which may be either in the form of hemolysis, either from immune or non-immune causes, or in the form of red blood cell sequestration. The hemolytic anemias are characterized by a decrease in the normal red blood cell survival, which is 120 days, and there is usually a concomitant increase in the rate of red blood cell production, or reticulocytosis, associated with this, and this may or may not be fully compensatory, depending on the severity of the hemolysis and how acute the onset is. The etiologies of premature red blood cell destruction can be either intrinsic, in other words, related to a defect of the red blood cell itself, or they may be extrinsic and outside of the red blood cell. So the intrinsic problems are defects of protein or hemoglobin synthesis, enzyme defects, or membrane defects. The extrinsic forms of hemolytic anemia are either on an immune basis, antibody-mediated, or a non-immune basis from mechanical, from sequestration, or from chemical destruction of the red blood cell. Clinical features that suggest a hemolytic disorder include a family history of anemia, jaundice, particularly if jaundice is pronounced in the newborn period, family history of gallstones, splenomegaly, or need for splenectomy. Certain ethnicities and race have a higher prevalence of some of the hemolytic disorders. In particular, sickle cell disease is most common in African and African American populations. We see hemoglobin E and hemoglobin E thalassemia in Southeast Asians. And then the African, Mediterranean, and Southeast Asian populations all have a high prevalence of alpha and beta thalassemia and also G6PD deficiency. The age of onset is important. This can present in the newborn period with more pronounced hyperbilirubinemia, anemia, and jaundice, although this is more commonly related to maternal antibody, such as Rh or ABO incompatibility. Splenomegaly should also suggest possible hemolysis. Laboratory markers that are good general screens for hemolysis include an elevated reticulocyte count, an increased indirect bilirubin, an elevated lactate dehydrogenase, or LDH, decreased haptoglobin, though I would note this is not helpful in newborns in the first few months of life, and an elevated aspartate aminotransferase, or AST. So if you're considering a hemolytic disorder, sometimes it's useful to send these laboratory tests to see if there is evidence for this. We'll start with the disorders of hemoglobin synthesis. So these kind of fall into three categories: the hemoglobinopathies, which are anemias caused by biosynthesis of abnormal globin chains that have altered physical and chemical properties; the thalassemias, this is a very heterogeneous group of microcytic hemolytic anemias that are caused by an imbalance of alpha and beta globin chain production; and then rare, but worth mentioning, the unstable hemoglobins. Alpha thalassemia is caused by deletion of any combination of any number of the 4 alpha globin genes. So the manifestations range from insignificant in the case of the carrier 1 gene deletion to fatal when 4 genes are absent that leads to hydrops-vitalis. Beta thalassemia is usually caused by point mutations on one or both beta globin genes, and up to over 250 mutations have been identified. There's great clinical variability in beta thalassemia, reflecting the degree of underexpression of the affected genes. There's the thalassemic phenotype for patients who have a severe form of thalassemia. They have brisk hemolysis, they have a hypochromic microcytic anemia, there's ineffective erythropoiesis, they can develop skeletal deformities from extramedullary hematopoiesis, in particular the skull and the hands, and they often have hepatosplenomegaly. Beta thalassemia syndromes are generally classified into one of 3 categories: beta thalassemia trait or carrier state. This is the heterozygous genotype characterized by a mild microcytic hyperchromic anemia with elevated hemoglobin A2 and hemoglobin F on hemoglobin electrophoresis. This is really not clinically important for the patient, except from a genetic counseling standpoint. Then in the middle is beta thalassemia intermedia. This is a homozygous genotype with moderate anemia, but not severe enough that the patient requires red blood cell transfusion. And then there is the most severe form, beta thalassemia major, also called Cooley's anemia. And this is also a homozygous genotype with severe transfusion-dependent anemia. Alpha thalassemia trait or carrier state will often show up as hemoglobin BARTs noted on a newborn screen. It may not be detectable on hemoglobin electrophoresis that is done later in life, but one should suspect it if there is microcytosis in the setting of normal iron studies in a patient of an appropriate ethnic background, again with the highest prevalence being among Africans and Southeast Asians. And like beta thalassemia trait, there's really no clinical relevance for the patient, but this is important to know about for genetic counseling purposes. Treatment of thalassemia. So for trait, there is no treatment required. I would put forth that not all of these patients need to be seen by a pediatric hematologist. It's often apparent from the CBC, from the hemoglobin electrophoresis, or it's identified in the newborn screen, and it's really just important to educate the family about it and know that this is not iron deficiency and the child does not require iron supplementation. Though, of course, a patient with thalassemia trait can also have iron deficiency anemia, and that's where the ferritin can be so useful in distinguishing between the two, although they may be together. Patients with the severe form of thalassemia, beta thalassemia major, require chronic transfusion support. And of course, this leads to the major problem of iron overload, such that patients will also need chelation therapy. Splenectomy can sometimes decrease the transfusion requirement, and bone marrow transplant can be curative if the patient has an appropriate donor. We'll move on to talk about the hemoglobinopathies, sickle cell anemia being the most important of these. This is a moderate to severe normochromic, normocytic anemia with a reticulocytosis. The genetic defect is a mutated beta globin chain that is caused by a single amino acid change of glutamine to valine at position 6, which leads to hemoglobin S. Patients with the carrier state are hematologically normal, essentially. The homozygous, or what we call hemoglobin SS disease, is the most severe form of sickle cell disease, but there are several different types of it. There are about 1,500 children born in the United States annually with homozygous hemoglobin SS disease, and 20,000 children born per year in equatorial Africa. And about 8% of African Americans are carrier of sickle cell. The severity of sickle cell disease clinically depends on the genotype, with the major types being SS, SC, and S beta thalassemia, and also on the percentage of fetal hemoglobin that the patient has. Fetal hemoglobin is relatively protective against sickling complications, and there are some patients who have what is termed hereditary persistence of fetal hemoglobin, where they're actually fortunate to have high levels of fetal hemoglobin that persist beyond the first year of life and reduce their sickling complications. The major clinical complications that patients with sickle cell disease have are those of hemolysis, severe anemia, aplastic crisis, in particular from parvovirus B19 infection, jaundice, gallstones, cardiomegaly related to a chronic high output state, and sometimes poor growth. They also have vaso-occlusive complications, most prominently painful crises. These tend to be in the hands and feet in infants, termed dactylitis, and then most prominently in the long bones in older children, though it can also be abdominal or chest wall and ribs. Acute chest syndrome is a serious complication of vaso-occlusive from pulmonary infarcts. Patients can develop stroke, retinopathy, and priapism, and these are all serious complications. Patients with sickle cell disease have varying degrees of splenic dysfunction. They can have full infarction, or they can have sequestration, where the spleen becomes acutely enlarged, pooling red blood cells and leading to severe anemia. We know very well that these patients are at high risk of sepsis from encapsulated bacteria because of their splenic dysfunction. Because of this, many states screen for sickle cell anemia in their state newborn screen, so that children can be identified early, education can be provided to parents, and penicillin prophylaxis for pneumococcal infection can be instituted. For pain crisis, the first-line treatment is nonsteroidal anti-inflammatory agents, but patients with the more severe sickle disease also often require opiates for painful crises. It's important that children with sickle cell disease avoid dehydration, prolonged exposure to cold, and hypoxia. And the indications for transfusion for sickle cell disease are not just anemia alone, because again, most of these kids live at a very low hematocrit. They may have a hematocrit at baseline of 18, 19, 20%. So the indications for transfusion are clinical, including acute chest syndrome, stroke, aplastic crisis, splenic sequestration, or if the patient is going to undergo general anesthesia, which is associated with an increased risk of acute chest syndrome. Hydroxyurea can be useful in patients with sickle cell disease. The mechanism is that it increases fetal hemoglobin, which again is protective against sickling. And as in thalassemia major, bone marrow transplant can be curative for sickle cell disease. Hemoglobin E disease is another hemoglobinopathy worth mentioning. This is also a beta globin mutation, as is hemoglobin S. Tends to be a rather mild disease with a microcytic, non-hemolytic anemia, and it's very prevalent in Thailand, with up to 20 to 30% of the population affected, and also of other people of Southeast Asian descent. It can contribute to potentially severe anemia when it's co-inherited with beta thalassemia, which is also very prevalent in Southeast Asia. We will talk now about the erythrocyte membrane defects, the most common being hereditary spherocytosis. This is a congenital hemolytic anemia of varying severity that is caused by a defect in the red blood cell cytoskeleton proteins. It leads to loss of membrane, to decreased deformability of the red blood cell, and to shortened red blood cell survival. This is usually inherited in an autosomal dominant manner, so patients will often have a positive family history with parents who have jaundice, have had gallstones, have maybe had a splenectomy. It is most common in people of Northern European descent, and it affects about 1 in 5,000 persons in the United States. These patients are not always anemic. Sometimes they have compensated by a high reticulocyte count, such that at baseline, when they are well, they may have a normal hematocrit. But classically, they have a high MCHC, and of course, they will have spherocytes seen on their peripheral blood smear. And the diagnosis is usually made on the basis of an abnormal osmotic fragility test. The clinical course of hereditary spherocytosis is quite variable, but most patients, about half of patients will present in the newborn period with jaundice, with a high reticulocyte count, with spherocytes, and a negative Coombs test, ruling out an immune basis for hemolysis. About half of children are anemic, half are not. Half of adults will at some point develop gallstones. This isn't usually seen in the pediatric population. And many children will have splenomegaly, half of infants, and then up to 95% of older children and adults. Patients have two major problems related to hereditary spherocytosis. One is they're at risk, like sickle cell patients, of aplastic crisis, in particular from parvovirus. And they also may have increased hemolysis during times of stress. So during infections with febrile illnesses, the hemolysis will be more brisk. They may become more jaundiced and drop their hematocrit and become more anemic. Splenectomy can essentially correct this condition as it improves and normalizes the red blood cell survival. But we try to defer this until after 5 years of age because of the higher risk that young children are at of overwhelming sepsis from encapsulated bacteria. There are other less common membrane defects, hereditary elliptocytosis. This is an autosomal dominant condition that may or may not have hemolysis, many not, and they will classically have elliptocytes seen on their smear. There's a rare condition known as hereditary pyropoikilocytosis. This presents in the newborn period with the hemolytic anemia with a strikingly abnormal smear, and it usually improves with time. And then there is hereditary stomatocytosis. Next, to discuss enzyme deficiencies, we've covered membrane and we've covered protein defects. And the last category of intrinsic hemolytic disorders are the enzyme deficiencies. The most common of these is glucose 6-phosphate or G6PD deficiency. G6PD is the rate-limiting enzyme in the pentose phosphate pathway, and it protects the red blood cells from oxidant stress. This is diagnosed by measurement of the G6PD level, and some states include this in their newborn screen. Inheritance is X-linked, and this affects 10% of African American males and 1% of African American females. It's also prevalent in South Americans, in Southeast Asians, in the Middle East, and in Mediterranean. There are 3 variants of G6PD deficiency, and they range in severity from quite mild to actually severe form with chronic hemolysis. Most patients are hematologically normal most of the time, except if they're exposed to an oxidative challenge. So the classic history is a patient with acute onset of jaundice, with dark urine, and with severe anemia after exposure to an offending agent. And these patients will have hemoglobinemia, hemoglobinuria, and bite cells on their smear if you study them during the acute event. The causes of hemolysis, the classic is fava beans, and this disease is often called favism because of that association. Naphthalene, which is in mothballs, certain infections, and certain medications such as the sulfa drugs, aspirin, and antimalarials can all provoke a crisis. It's very important to counsel the family about this, and after this is identified on a newborn screen, we inform them about the need to avoid exposure to oxidative agents. And we may consider screening a high-risk population prior to the prescription of medications that we know are at high risk of causing hemolysis. The other red blood cell enzyme defects are rare. Pyruvate kinase deficiency is the second most common, and it's the most common glycolytic enzyme deficiency. It's inherited in an autosomal recessive manner, also has a wide range of severity, and can lead to a severe transfusion-dependent hemolytic anemia. It can present in the newborn period with severe hyperbilirubinemia necessitating exchange transfusion, and as with hereditary spherocytosis, the anemia may improve with splenectomy. And last worth mentioning is hexokinase deficiency, also autosomal recessive with a similar presentation to pyruvate kinase deficiency and a very rare condition. Now we will move on to discuss the extrinsic hemolytic anemias. So these are anemias that are not from an actual red blood cell defect, but something that's extrinsic to the red blood cell. Hypersplenism is one form of this, where an enlarged spleen leads to sequestration of the red blood cells, and this can affect other cell lines as well, most notably the platelets. Autoimmune hemolytic anemia, alloimmune hemolytic anemia, the microangiopathies, which are really mechanical destruction of red blood cells, including hemolytic uremic syndrome, disseminated intravascular coagulation, and thrombotic thrombocytopenic purpura, which is rare in children. Hemolytic anemia can be mechanical, related to an artificial heart valve and turbulent blood flow in the heart that leads to destruction of red blood cells. There's a rare condition, paroxysmal nocturnal hemoglobinuria, and Wilson disease. The immune hemolytic anemias are characterized by the coating of red blood cells with immunoglobulins, with or without complement, that results in lysis of opsonized red blood cells in intravascular or extravascular sites, with the extravascular sites being the liver or the spleen. The direct antiglobulin test is the usual way we make this diagnosis, also called the Coombs test. Patients with this will have a reticulocytosis, and microspherocytes on peripheral blood smear. So sometimes it can look similar on smear to hereditary spherocytosis, but the Coombs test will be helpful in distinguishing between the two. The autoimmune hemolytic anemias are generally classified as warm or cold, depending on the thermal amplitude of the antibody. They can be primary or secondary from some underlying autoimmune disease, from infection, from malignancy, or associated with particular medications like penicillins and cephalosporins. The warm antibody autoimmune hemolytic anemia is an IgG antibody, and clinically this generally presents with the sudden onset of pallor, jaundice, and dark urine, and there can be a rapidly progressive severe anemia with hyperbilirubinemia. In this condition, the hemolysis is primarily extravascular, takes place in the spleen, and patients will very often have splenomegaly. This is frequently responsive to corticosteroids, and in the more chronic refractory forms, we also sometimes use rituximab, intravenous immune globulin, splenectomy, or immunosuppressant agents. Patients may require transfusion for life-threatening anemia, and this is more likely to be a chronic and refractory condition when it is secondary to an underlying systemic disease such as lupus. Cold antibody hemolytic anemia is usually an IgM antibody with complement, and the classic infection that this follows is mycoplasma. It can also follow viral infections, including Epstein-Barr virus, cytomegalovirus, and herpes zoster. This tends to be a milder autoimmune hemolytic anemia than the warm IgM antibody, with milder hemolysis and a self-limited course. In contrast to warm antibody, the hemolysis is usually intravascular with opsonized red blood cells cleared in the liver. And it's important for patients with this to keep them warm because cold body temperature will worsen the hemolysis, and to consider warming intravenous fluids or blood products that are going to be administered to the patient. Steroids are generally not helpful in this type of hemolytic anemia. There are also alloimmune hemolytic anemias. These are related to active immunization from administration of incompatible blood or by passive transfer of maternal antibody, such as seen in ABO or Rh isoimmunization. So these are conditions we see in the newborn, Rh disease or ABO incompatibility. The Rh disease, the Rh antigen is much more immunogenic than ABO, so it's often a severe condition with pallor, with jaundice, with organomegaly, frequently necessitating exchange transfusion. The ABO antigens are more weakly expressed on newborn red blood cells, so the hemolysis is generally much milder. The direct Coombs test is the useful way to make these diagnoses. It's always positive in Rh disease, but it may be negative in ABO incompatibility. And just one slide about neonatal anemias. Neonates can have anemia from lots of different etiologies. Hemorrhage, so babies who are anemic at birth, this indicates hemorrhage in utero. And this can be in the form of fetal maternal hemorrhage, which can either be acute or chronic, and the diagnosis can be made by performing the Kleihauer-Betke test, which detects fetal red blood cells in the maternal circulation. In the case of twins, there can be a twin-twin transfusion syndrome, where one baby is polycythemic and the other is anemic. Or there may be blood loss around the time of birth from traumatic delivery, from a ruptured umbilical cord, or from a large cephalohematoma. As mentioned, babies also have hemolytic anemia. This can be from congenital red blood cell defects, such as membrane defects, hereditary spherocytosis, enzyme deficiency like G6PD deficiency, or from hemoglobin from thalassemia, although the beta globin defects tend to present later in life, later in infancy, as the fetal hemoglobin declines. Babies can also have acquired red blood cell defects, immune, as we discussed, the Rh and ABO incompatibility, and non-immune problems from infection, from asphyxia, from acidosis, or from vitamin E deficiency. Lastly, I want to mention some reasons that should prompt consideration of referral to a pediatric hematologist. Not all patients with anemia necessarily need to see a hematologist. But in general, many physicians consider a hemoglobin under 7 to be an indication to at least consider packed red blood cell transfusion. So in general, patients with severe anemia may benefit from evaluation under the guidance of a pediatric hematologist for help with determining the etiology and patient management. Anytime that more than one cell line is affected, so if it's not just the red blood cells but also neutrophils, white blood cells, platelets, that should raise the level of concern for underlying bone marrow dysfunction, as should macrocytosis. The presence of short stature or congenital anomalies, which can coincide with some of the inherited bone marrow syndromes, is another reason to consider involving a pediatric hematologist. And then I would say when there is no ready explanation and there is more than mild anemia, or if there's failure to correct with what seems to be appropriate treatment, such as the case with iron deficiency. Most of the time, I think it's not necessary for patients with iron deficiency or thalassemia trait to necessarily see